Hi, this is Brian Kim. I want to share with you case number 110 in the best way to do cataract surgery series. This is a 1 plus dense lens. It's really not a dense lens, but it's also a small pupil. And so you're going to see my standard technique, double chop, cross chop, mechanical fracturing techniques, how I'm able to hook lens pieces up out of the bag confidently, being able to crush the lens pieces without worry about being able to get the lenses out of the bag. And really, I don't like to use hooks or rings in this case. One, because I don't feel like I need it. It also causes more potential trauma to the iris. And so whenever I'm dealing with a case like this, I feel fairly confident I can still do the case without those extra instrumentation. So you can see this is the eye. The pupil is okay. It's not really terribly tiny, but it's also not that big. I use a corneal marker, which will help me to center and size the rexus. Make my paracentesis incision first on the right side and then the left side, making sure the incision is flat to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral lidocaine, and then some intracameral epinephrine, and then now some dispersive viscoelastic. Of course, the viscoelastic provides some viscodilation. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, turn the eye towards me, and then I enter. Push some more viscoelastic at the end there. Go in with the forceps sideways. I puncture the center, pulls towards me, and then sweep a little bit to the right, which creates a little bit of a tear and a flap. Grab the right side of the tear, and I go around circumferentially. Again, because I was able to make the pupil a little bit bigger with viscodilation, the pupil size now here mirrors the size of my marks that I made before. So I go around circumferentially, grabbing and re-grabbing here. The rexus is fairly uneventful with this patient. So this is capsular fornix hydrodissection technique. I place the cannula under the rexus edge contra-incisionally, point the tip down, get a nice wave, being very careful, very, very slowly. You see I'm doing the rexus very slowly to avoid iris prolapse. So that's a very important tip when you're dealing with that situation. I decompress on the left side, turn the tip to the right, hook the peripheral lens, and the lens begins to spin very nicely there. Irrigate the surface of the cornea, adjusting my sleeve length, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material, placing the chopper under the rexus edge contra-incisionally, the phaco tip vertically sub-incisionally, bringing the instruments together, cutting and crushing and dividing the lens in half, placing the chopper around the right heminucleus, pulling it centrally towards the phaco tip, cutting that in half as well. That's double chop and cross chop. Using some vacuum to lift that first quadrant up out of the bag, crushing the lens between the instruments, and then emulsifying the lens pieces. Placing the chopper around the second quadrant, pulling it towards the phaco tip with another cross chop maneuver, and then emulsifying the lens pieces. Turning the second heminucleus in front of me, placing the chopper around the lens piece, pulling it centrally towards the phaco tip, dividing the lens in half, and then using some vacuum to grab that third quadrant, crushing the lens between the instruments, and then emulsifying the lens pieces. Again, this is a soft lens, and so really the maneuvers are quite easy. Lens disassembly is fairly easy, and so I'm not really worried about, zonulopathy and having to utilize a lot of ultrasonic energy in these cases. So I really feel very confident I can disassemble these lenses really quite safely without using a device to expand the pupil. So hooking that last fragment up and then emulsifying it, grasping the epinucleus anteriorly with the phaco tip, loosening it up, hooking it up with the chopper, loosening it some more, and then grabbing it again with the vacuum, and it tumbles out nicely there. Make sure I keep the chopper deep in the bag to protect the posterior capsule. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the iron handpiece. And I made sure that the iris wasn't going to prolapse. This is not really an IFIS iris, so I didn't feel like that was going to happen. So I use the INA tip, starting subincisionally, removing the cortical material, and then going around circumferentially. Again, trying to grab the anteriormost part of the cortex as I go around. Switch to polish mode and going under the rexus edge more confidently, knowing that I'll be able to polish and remove lens material without accidentally grabbing the capsular bag. Polishing also the posterior capsule, because there's some fine lens material that's adherent there. Getting to that subincisional space, there's some adherent material there as well. So I use a cannula to pulse the subincisional capsular fornix here. And it's fairly clean in this case. Go ahead and inject some cohesive viscoelastic to fill the bag. I'll go ahead and polish. Because the pupil is small, I'm not going to really polish, because all it will do is liberate more iris pigment as I try to sweep. So I go ahead and place the single piece acrylic lens into the capsular bag. I go in with the INE handpiece, irrigation off, activate irrigation, making sure both haptics are off the optic, making sure the leading haptic is in the bag. I also like to place a Maltzman at the same time, simultaneously, being able to retract the pupil edge to be much more confident by directly visualizing each haptic in the bag. Getting underneath the optic, tilting it and rotating it, removing the viscoelastic within the bag, repositing the lens optic. And once I'm confident that both haptics are in, I take the Maltzman out. I'm polishing under the rexus edge, turning the lens haptics. Switch to visco mode, removing all the viscoelastic from the anterior chamber here, and then I'll hydrate my incision. So again, this is a fairly soft lens, about a 1+ density, not super soft, but enough to require some crushing forces with a double chop, cross chop. You saw this was a fairly small pupil, but not floppy really, and so I felt really confident being able to disassemble the lens with double chop, cross chop, mechanical fracturing techniques, hooking lens pieces up out of the bag. I never feel worried that I can't get a lens out. Again, because I'm not going after lens pieces with vacuum, I don't ever have to worry that I'm going to accidentally grab something I shouldn't, like the posterior capsule. So using the chopper is really a very powerful way to take advantage of a very safe way of grabbing pieces up out of the bag. And so I do this routinely with all the cases. I never worry that I'm not able to take a lens piece out. So I really do feel like this is the best way to do cataract surgery when you're dealing with a small pupil and a soft lens. So I hope this was helpful to you, and I thank you for your attention.